So I think that the biggest innovations in coronary physiology and imaging have started with the physiologic new measures, the non-hyperemic measures of IFR and PDPA, and most recently QFR and DPR. We'll go over those, the angiographic estimates of FFR, as well as some advances in IVUS and OCT. So the newest software from Volcano allows you to do angiographic co-registration of the IFR pullback along with your angiogram. I'm finding I get this in my lab. I'm very excited. And this will allow me to predict exactly which area of the artery I need to stent. And this could be very effective in pinpointing in a diffusely diseased vessel exactly which area of the artery needs to be stented most. This really helps you to diagnose patients who have focal disease, which are most easily amenable to stenting, as opposed to people who have diffuse disease, who might be better treated with bypass surgery or very long stents. So I think this is an extremely helpful tool. And most recently, the publication from JACC Interventions 2018 April showed that the IFR gradient, the IFR pullbacks, were actually quite predictive of what the post-PCI IFR would be. So in other words, you could pull back and you could measure how many units of IFR you've changed and actually predict what your post-PCI IFR would be. We can't do that effectively in FFR because there's a hyperemic crosstalk that happens, such that when you treat one of the serial lesions, you increase the flow across the other lesions, and therefore increase the pressure effects of those other lesions. With more resting ratios, the resting flow tends to be a little more constant, and therefore the relationship between pressure and flow seems to be a little more constant when treating one lesion after another. So these are the results of the IFR gradient study, which in 173 patients showed that the average difference between the predicted IFR and the post-PCI IFR was only 1.4%. There's a little bit of spread, but it's actually quite predictive. And this can be very helpful in planning out your interventions, as well as whether you should intervene on a very diffuse disease. For those of you who don't have the Volcano system, Bantvir and others have shown that you don't need the Volcano system, the Philips Volcano system necessarily. It turns out that any diastolic pressure ratio calculated over this pressure period is actually numerically equivalent with a correlation of 0.99 to any IFR value. And so that every company may be developing, or actually in the process of developing DPR or diastolic pressure ratios, which will allow you to correlate the findings here and correlate, therefore, the findings of Defined Flare and IFR Sweetheart to any company's software. So that's very exciting. You can also predict FFR or IFR potentially in the near future from an angiogram. And taking just fixed angiograms or three-dimensional angiograms, you can do computational fluid dynamic modeling to create a three-dimensional shell of the artery and model what the pressure is at the distal part of those arteries. And initially, these were pretty much guesstimates, about 80% agreement, which were not bad. But CathWorks and others have tried to develop protocols which allow you to calculate the distal FFR on these vessels just from angiograms. And they're getting a lot closer. The CathWorks protocol is coming within 0.05. When FFR has a variation of 0.02 to 0.03 after serial measurements, when you're getting down to 0.05, then you're getting pretty much close to the repeatability of FFR. The Morris et al. has demonstrated on their protocol that in a small population, that they can get within actually 0.01, which is very exciting. The most advanced one right now is the QFR from Europe, where the QFR calculated from, these are all branded names of angiographic estimates of FFR. The three different protocols of measuring estimates of estimated FFR came with areas under the curve of up to 0.92 to diagnose a significant lesion defined as an FFR less than 0.80. So when you're getting that far along, it may be very helpful to have a three-dimensional map of the FFRs of all three of your vessels just from the angiogram. This takes as little as 3 to 5 minutes and is really the future. I think one of the interesting things that we talked about new stents, but this is a novel intervention where you could put a pressure sensor onto a stent and possibly interrogate it intermittently whenever you're concerned that the patient might have restenosis, because the pressure and flow parameters of that stent might change over time. This is definitely something that is up and coming and might be something that we see in the next 5 to 10 years. So this is exciting. Moving on to IVUS, we know that there's differences in IVUS, and they've finally made a lot of progress in the past few years on improving the IVUS platform. We know the phased arrays catheter is very convenient, but tends to give you fairly coarse images. The rotational IVUS catheter in the center demonstrates a much better image quality and fewer artifacts. And the HD IVUS, which are improving the resolution of the frequency from 40 megahertz to 60 megahertz, comes with an improvement in resolution and diagnostic capabilities. So in this paper here, you can actually see the double-layer stent platform of a BVS stent, and actually compare that with the HD IVUS versus the 40 megahertz IVUS, and you can see that the HD IVUS can diagnose the stent coverage and the stent apposition a lot better than the 40 megahertz IVUS. HD IVUS can also be much more effective in detection of plaque rupture or detection of dissections, as in this picture. It's fairly obvious in both pictures, but the resolution is much more clear in the 60 megahertz version, where you can actually see the flap of the dissection. The HD IVUS is closer to the OCT standard for the BVS, where you can actually see those stent struts that are malapposed. So it's coming closer to OCT with HD IVUS, all with the lack of needing to inject contrast, which might increase your risk of contrast nephropathy. So what about OCT? OCT has made a number of advancements over time, especially in display and resolution. So in this 3D OCT version, they model where exactly the stent is. They can tell you exactly what the apposition is of the stent, with green being good and red demonstrating areas of malapposition. The pictures are becoming very colorful and are really impressive when wanting to show to the patients, to show them what you've done. Clinically, I think they're useful for side branches, and the latest thing is actually OCT-FFR Coregistration, such that you can actually see where the side branch is, the red line here, and you can see that there's no step up of pressure at the ostium of this side branch. And this OCT-FFR Coregistration is truly the next step in development. For several years at UC Irvine, we've been working on the OCT and IVUS combination catheters. These tend to be a little bit bulkier and trying to combine the image qualities, the depth of penetration of IVUS with the superficial resolution of OCT. And this has been going on for a few years. I'm not sure exactly the utilization of this. Most of the benefit seems to be from the OCT, but I think it's something of interest. I think the latest things are actually putting imaging into action. It's one thing to see good pictures, but it's another thing to actually see it and help you guide where you want to go. So for the CTO operator, the forward-looking IVUS for CTO, mounted with an RF ablation needle, allows you to potentially direct your catheter away from the wall when it comes close to the wall, while also burning towards the center of the lesion. So this catheter sounds like it's going to be extremely helpful for antegrade CTO attempts, and maybe coming down the pike. Forward-looking IVUS, confirm true lumen position of the wire, reduce the risk of perforation, and use RF energy to facilitate antegrade crossing. For those of us who aren't as skilled as Manos is in crossing antegrade. It's compatible with most existing wires. Another technology which I think is exciting, at least currently in the peripheral space, is actually using OCT, forward-looking OCT, to guide where you are in the vessel. Again, trying to avoid the vessel wall and redirecting the catheter towards the center of the lumen whenever you're encountering the external wall. Don't ask me how the technology works without contrast or anything, but they are able to image in the peripheral space currently the vessel wall and avoid it and use it in chronic total occlusions. Avinger, unfortunately, this console currently costs about $250,000 and is used in the peripheral space only, but I suspect it's only a matter of time before this technology migrates to the coronary space. So to summarize, I think there's a lot of excitement still going on in the imaging space, especially in physiology and coregistration, and effectively in new technologies for crossing CTOs. Thank you very much.
Thank you, Arnold. You were perfect, right on time, giving us a little bit of time to have some discussions. There's no question that we are really, really innovative in this space. A lot going on where we were a decade ago and where we are today. But what's really important is the penetration of imaging in our daily practice. So before we move forward, let me just ask, how many of you are using imaging in more than 50% of your procedures? Imaging, not physiology, imaging. How many of you are using it in more than 20% of your procedures? how many are using it in less than 10% of your procedures? Less than 10%. So not everyone is answering, but the idea is that the penetration of this very important technology that everyone is innovating like crazy in is not really being used. Why do you think that is, Arnold?
Yeah, I think that's a great point. I think the latest data from Sky was that something like 9%, somewhere between 9 and 14%. I think actually Kirk Garratt mentioned that. I think it's clearly a reimbursement versus time issue. I mean, the reimbursement is not necessarily there for the hospital, and it's only modest for the physician for the time involved. It's also perhaps, even though we have excellent data on how IVUS improves outcomes in terms of MACE and stent restenosis, I think that there's still a disconnect, a cognitive dissonance about what we believe about IVUS, but not actually putting it into practice. And those things all go into our daily workday. We're all busy. We think that, okay, we've expanded it, it looks good, and therefore we're not taking the extra step to IVUSs afterwards.
Yeah, sure.
I'd just like to make a comment there. I think, excuse me, an important factor is the nature of your practice. So if you're doing a lot of CTO work and you have a CTO referral practice, you're going to use a lot more imaging than an average fellow or gal who's out there just doing community work. When you take out the left mains and the CTO population, I think imaging has, in my opinion, a very, very limited role. We've learned that physiology trumps anatomy in decision-making regarding which lesions require treatment. And if you don't believe that, then you're going to lean on imaging more heavily for sure. But I think if you accept that physiology is really the primary source of defining which lesions require invasive therapies, then naturally, you lean toward that. In our practice, we use far more fractional flow reserve than we do IVUS or OCT imaging today, with the exception of those carve-outs of left main interventions and CTOs.
So there's this big, huge trial that Ziad Ali is leading with Greg Stone and CRF on Illumian 3, where they're actually looking at OCT-guided stenting versus standard of care, and looking for the hard endpoint of improvement of MACE outcome. But I do think that we've all seen that probably the scarcity of use of this is one. It takes time. It's more costly. The bang for your buck is not as much as you don't see it. It's not immediate. And we don't have Chadi and Sani going in there saying imaging first, #image first. Dr. Gulati, why do you think this is, and should industry and everyone continue on the innovation path? Because as you see, and if you go to many of the companies are really working hard to basically be they even evaluate the image, they measure the stent length, the lesion length, everything. You basically, it's almost robotic. Why do you think, what do you think is going on?
Yeah, I mean, you guys have said it all. I mean, I couldn't have said it more beautifully than everyone on the table. I guess the bottom line is that stents are so darn good these days that we don't get a feel that there's late events in current generation stents. And so where you can tell us there's IVUS data from the old randomized studies, we're waiting on Illumian 3. I don't know about you, but I'd be shocked if we find OCT guidance is going to make a difference to hard endpoints. I suspect it's going to be neutral, but we'll see. But the event rates are so low with modern second generation stents. I struggle. It's just the sense that we're not going to impact that particularly by going with imaging. But there is this huge disconnect between the extent of innovation, the beautiful nature of some of the images, and the utilization.
It's incredible. And
so,
go ahead.
In our laboratory, same as Kirk's, is we use about 3 times as much FFR as we do imaging. And apart from the lesion sets that Kirk mentioned, like CTOs and left mains, I'm using FFR to figure out whether I should do something. I use IVUS and OCT to figure out how to do something, and maybe should I do something better. Remember, outside of weird scenario, really the only actionable thing after an IVUS or OCT for me is to post-dilate bigger. So I just post-dilate bigger. So I've been, in the bigger is better lab is where I learned.
And also there's the other one, the carrot in the room goes to FFR, right? Because our QIP, our quality metrics are measured appropriate use criteria that do have to do with the appropriateness. So there's a lot to talk about. I want everyone to kind of keep focused, because I am going to ask you all to vote where we should be innovating more or less, and where, because Manos has done such an amazing program to give us all the different areas. And